Morning, everyone.
I'm you can see our topic here, hot topics in infectious disease. I'll let you introduce yourself. I don't want to mispronounce your name.
Okay,
Um, uh, but go right ahead.
great. Well, my name is Shireesha Dhanireddy. I'm a professor of medicine here at University of Washington and in the Division of Allergy and Infectious Diseases, but on the infectious diseases side. And I'm a medical director at the Harborview Infectious Disease Travel Clinic, as well as the Madison Clinic and She Clinic. I predominantly see patients most of my time, but I do quality improvement work, particularly focused around improving care for people with substance use disorder and comorbid serious infectious diseases. But I guess I'm taking over this topic from John Lynch, who's been doing this for quite some time. I think I have, he showed me some of the topics that he's discussed. So along the similar vein, because we've been dominated by one particular infectious disease over the past couple of years, but I wanted to bring up some other infectious diseases as well. All right, so to get started, I have no financial relationships or conflicts of interest to disclose, and I was told that the word of the day is vector. Not sure what that means to you all, but it's appropriate for an infectious disease talk. All right, so I wanted to just give a COVID-19 update and then just give you a teaser about some other infectious diseases, threats and outbreaks that we have had or we potentially could have over the past year or coming year. So to start, where are we now with the COVID pandemic? As you know, in just 8 or 9 or 10 days, we're going to have the end of the pandemic federal funding, which many people is hearkening the end of the pandemic, but we all know that that's not necessarily true. As we're still seeing infections, we're not seeing nearly as many of the hospitalizations or deaths as we were before. We've sort of hit a new normal. This is where we are and where we have been. So we've seen over 1 million deaths. This is in the United States alone. As we know, there's many millions of deaths throughout the world, and over 100 million total cases. Although we know that that's probably lower than the actual cases given the advent of self-testing and people not necessarily reporting illness, particularly mild illness. But you can see all the trends are relatively down. This is as of last week or so, and that has continued. It hasn't gone up. This is sort of where we were in terms of the peaks and sort of the therapies that we've had that have come and gone. You can see that the largest peak was the Omicron, and that's where we are now. We continue to have Omicron variants that dominate, but you can see that completely overshadowed our initial waves of infection, albeit the mortality rates were much higher with the prior infection variants. So what are the risk factors? They're still the same as they were in terms of what makes people more vulnerable to severe disease and infection. We know age is a large contributor, and I'll talk about that when in reference to prevention and vaccination. But you can see that people 65 and over have significantly higher risk. And then when you add in comorbidities, including obesity, and that was defined as a BMI of 30 or over, which is actually pretty common in the United States to have that high of a BMI. And then diabetes, chronic kidney disease, chronic lung disease, neurocognitive disorders, and heart disease. And many of our patients have these comorbid conditions. So the risk factors for disease progression are actually quite broad unless you're young and have no comorbidities.
What about asthma? You don't see it there, but interestingly, you see the TV ads encouraging people to get vaccinated, saying that asthma is a risk factor. They're just misinforming the public.
No, I think it is a risk factor. And it's listed here as COPD, but I would include asthma in that. So for your patients that you're following, even if though they're young, that would be a risk factor for disease progression and more severe disease with any underlying lung disease. So patients of yours who are on biologics in particular for asthma, so their asthma is pretty severe, I would say they would be at risk for more severe disease. So here's some other factors here that then subsequently came out in terms of relative risk of death. And what you can see here is that it's when you have no conditions versus multiple conditions, those multiple conditions are additive, and so they significantly increase their risk. So if a patient of yours has asthma, also immunosuppression or asthma, and is pregnant, or asthma and overweight, though that significantly can increase your risk. So doing a full risk stratification is really important in terms of counseling for disease prevention with vaccination, but also for promptly getting treatment if they were to qualify for treatment, or if they do have these risk factors and they don't have any contraindications to treatment. So what is the treatment? There are a number of treatments, but I think the main one that I want people to think about that is still around is Paxlovid or nirmatrelvir, ritonavir. It's a mouthful to say, so most people are using the trade name Paxlovid. It was studied in non-hospitalized patients with mild to moderate disease and at high risk for disease progression. So again, using those risk factors. And it can be given to anyone 12 or over. So I know many of you are seeing pediatric patients, and so this is relevant to the adolescent population at least. So ritonavir is not a new drug. That's been around for quite some time. It's a protease inhibitor that is used in HIV, particularly for boosting levels of other drugs. And in this situation, that's the same. But because it's a pharmacologic booster, there are a number of drug-drug interactions, and it's important to note other medications and review their list to see if there's any significant drug-drug interactions. It's 5 days, 3 tablets twice a day. There is a renal dosing that is slightly less for patients with lower GFR, but it's 5 days. In terms of how it was authorized for emergency use, and will probably soon get an FDA approval. It's not yet approved, but imminently will be so. The endpoints in that study were really hospitalizations or death. So it's not looking at time to symptom decrease or your time to getting asymptomatic. That wasn't really the draw for this study. It was really to reduce hospitalizations and death. And it was an 88% lower risk of those things. I will say that we've, at UW Madison COVID Therapeutics, we've been prescribing it even when there was a shortage or supply issue initially upfront. And when we gave it to our very high risk immunocompromised patients, I think the main thing that we heard back, and that has been shown in studies, is that the altered taste or dysgeusia. And to some that can be quite significant. So I always counsel patients to take lozenges or candies that they can suck on afterwards to try to get that awful taste. Some people said that it was like gasoline in their mouth and they would prefer not to take it compared to just dealing with the symptoms of COVID. One other important thing to note is actually potential for rebound. This has been shown to actually happen with COVID itself, even in the absence of treatment, where people have an improvement in symptoms and then a few days later can have a rebound in those symptoms. It has been definitely described in patients who've received antiviral therapy like Paxlovid to happen 2 to 8 days after the completion of the 5-day course. And what happens is that people have the same symptoms happen again, but maybe milder. And there's no additional treatment necessary. Some people were extending the course of treatment, but that is actually not recommended at this time. We may see that certain patients, like immunocompromised patients, it's recommended with further investigation to do longer courses, but at this time, it's still 5 days. The important thing to note is that people should restart isolation once with those symptom re-onset of those symptoms and for that 5-day period, just as is recommended for the initial symptoms. So this can be quite inconveniencing to patients who made it through the 5 days, felt better, made it through the 5-day course, felt better, and then had a rebound and had to reset their course for isolation. And the rebound rates are reported to be at 3.5%, but anecdotally, it seems like people are definitely higher than that in real world experience, maybe on the order of closer to 8 to 10%. The other option that I'll mention is remdesivir, and this is really for people who are very high risk, so have multiple risk factors, and for whatever reason can't get Paxlovid. And I think at UW Medicine, the only population we're really using this for is actually solid organ transplant patients who are on tacrolimus. So the calcineurin inhibitors have significant drug-drug interactions with Paxlovid and can affect the dosing for Paxlovid and can lead to, if patients are at risk for rejection, then this is something that we would really want to be cautious for. So we offer remdesivir. It was also studied in a similar population for mild to moderate disease, but high risk for progression, and the outcomes were the same: hospitalization or death. They did look at medical visits as well. The unfortunate thing about remdesivir, which has been our first antiviral that's been available for treatment in hospitalized patients, is that in this study, which was for non-hospitalized patients, it used a 3-day IV course. So this is asking someone to come back in every day for 3 days who's sick with COVID, and isolating in the hospital or an outpatient setting to get an infusion. So in our system, we only have one place that is offering this currently, and that's the Northwest Infusion Site. There are a couple of other places throughout the state that are offering this as well. And again, this is a backup for patients who cannot get Paxlovid due to drug-drug interactions and who are at very high risk. And this is the data from the Pine Tree study that was published in the New England Journal that showed, again, a very significant reduction on the order of 88%, similar to Paxlovid. So you can see here an 81% lower risk of medical visits, and the it had an acceptable safety profile, but again, the inconvenience of coming in for 3 days in a row. Lastly, the only other option that's available for treatment for COVID is molnupiravir. It was also studied in a similar population, but this is only for adults 18 and over. It's not recommended for children, and there is a warning because it can be teratogenic, and so it's not recommended in pregnancy. So this is also a 5-day oral course of 4 capsules. This is an alternative when the other 2 are not available. So if they can't get Paxlovid, and so in a situation of not being able to get Paxlovid is end-stage renal disease, Paxlovid is not recommended with in patients with very low GFRs. This could be an option. Again, the reason that this is not a preferred option is really related to the efficacy. And you can see here that it's really not as good in terms of looking at these Kaplan-Meier curves, and the risk of hospitalization or death is only on the order of 30-something% rather than 80-something%. So again, this is a backup for patients who need treatment but are not able to get Paxlovid and can't access remdesivir. We do offer it in our system to patients who are not solid organ transplant patients and can't get Paxlovid. So here are the array of options right now summarized. We used to have other medications, so probably many of you heard about the monoclonal antibodies, which we were using Regeneron was one of them that was early on, but then with the Omicron variants really showed medication showed no efficacy. And then with the newer variants, bebtelovimab and the prophylactic Evusheld, also monoclonal antibodies, are no longer effective. And so their EUAs were pulled. And so we're left really with the direct antiviral therapy as the monoclonal antibody therapy we can't keep up with in terms of the mutations. And I don't know of any others in the pipeline immediately that would be options for patients, particularly for preventative therapy aside from vaccine. I think that's where patients really are lacking. There are some who may not respond to vaccine due to, I don't know how many of you see patients with immunodeficiencies. I know that some of you do, but that is a concern, that lack of immune response to vaccine, and how else can we prevent infection in some of these patients. Evusheld was a passive infusion of antibodies for COVID, and there is nothing like that left. Given that is no longer active. And so it is a hole in our armamentarium for COVID prevention. Currently, we only have COVID vaccines. So what's next in terms of what can we do for prevention? We know that mask mandates are gone in the healthcare settings. There's still a little bit of a debate about what's going to happen. I know in our institution that's going to continue, at least for now. We know that there has been in-hospital transmission from coworkers to coworkers, as well as employees to patients and patients to patients. In the absence of masking, I think we're going to continue to screen patients, particularly on the inpatient setting. On the outpatient setting, we're really not screening anymore. We're still asking patients to mask, which some of them are grumbling about, but for the most part, things are kind of at a lull. We know that there are some variants of concern that are circulating. Arcturus is the most recent one that people are concerned about. We haven't heard any reports of increased hospitalizations or death with that new variant, which is a variant of Omicron. But that one can manifest with conjunctivitis, which was a little bit a new kind of symptom that's related to COVID. And for the most part, symptoms are fairly mild. And this is just the projection from IHME. We don't really know what's in store, but we're kind of waxing and waning. We do think that there will likely be another uptick in the fall with our respiratory viral season. And there likely will be new recommendations for prevention alongside our annual flu campaigns. So our current vaccine recommendations, just mid-April, there was a significant change. So previously we had a monovalent vaccine that was our original COVID vaccine that was still recommended if someone hadn't received the primary series. We've been pretty good in Washington State with our primary series, but there are some patients that are still holdouts that never got vaccinated. At this point, monovalent vaccine has been pulled, so no one should be carrying it, is no longer recommended. And bivalent vaccine, this is related to the mRNA vaccines, may be given as an initial dose. There is not recommendations to give 2 doses as the initial vaccine at this point. The bivalent vaccine has been available since the fall of 2022. If patients haven't received the bivalent vaccine yet, give it to them, no matter their risk factors. However, if they already received it and they're 65 and over or immunocompromised, they are eligible for a booster if it's been more than 2 months since they received their previous one. There is some more permissive recommendations or advice about boosters at this point, particularly for immunocompromised patients. They may get more than 1 bivalent booster depending on timing of their transplant, let's say, and or myeloablation, and if they are felt to need repeat vaccination, it is at the discretion of the provider to go ahead and repeat that vaccination based on risk and immunosuppression. So hopefully simplifying some of these recommendations in the fall. I think we'll see some more blanket COVID booster recommendations with the bivalent. There is not a new formulation at this point. The new variants are all still felt to be covered by this vaccine, but I think the main thing that we still want to emphasize for our vaccine patients who are holding out, that are don't believe that the vaccines work because they know people that have gotten COVID even after vaccination, is to really stress the point that this is for prevention of death and hospitalization and for protection of our community and those more vulnerable in our community, rather than just thinking about personal health, because many may just have mild symptoms and not want to get vaccinated. And so really, that's what I let people know, that this is really more of a community effort, similar to our flu campaigns. We know that young, healthy people aren't going to necessarily die of the flu, but we recommend that everybody get vaccinated for the greater good of our community. Okay, so that's COVID. I don't know if people have any questions about COVID as it pertains particularly to the allergy population, or any questions
I have
about
a question.
vaccine. Yeah.
This is a little out of your area, but what's your opinion on the origin of this virus? Was this a lab leak? Was this natural? This comes into the media,
I think
and then
it's
it
natural. I
Huh?
think it's natural, but I'm just speculating. It's not. I'm not a virologist and or an epidemiologist in that way, that studies these viruses in that way. I think there's been lots of theories, but it's given climate change and lots of densely populated areas where there's lots of potential for zoonotic diseases transferring to humans. I think it is very plausible. This has happened before, with SARS-CoV-1. I don't know why it wouldn't happen with SARS-CoV-2. For those of you maybe younger, SARS-CoV-1 was over a decade ago, and it was felt to be also a zoonotic from bats to human transmission via other animal hosts. So yeah, I don't know. Did you have a theory, Len?
No, not at all. It's just,
Okay.
that had been quiescent, and then certain governmental agencies came out with an opinion that it was a lab leak, or more likely than not. And then you don't see any discussion of this for a while. But it raises another question that you mentioned, SARS-CoV-1. Why do some of these viruses burn themselves out and disappear, and others become endemic?
Yeah, I think, a lot of it has to be with the innate characteristics of the virus, as well as the initial point of infection. We know that SARS-CoV-1 was able to be really localized and never really spread outside of China. And what we see with SARS-CoV-2 obviously is very different. And I think one of the things with SARS-CoV-2 that was really off the bat concerning was transmission during asymptomatic infection. And that, I think, specifically at early on led to a significant uptick and rapid expansion of this infection globally. Because if we're only infectious during that symptomatic period and people are quickly symptomatic and shedding virus, they're mostly isolated, or there's less impact because there can be isolation and quarantine. We knew that patients were, 3 to 5 days even of asymptomatic significant shedding. And that was the significant concern there. I also think that there was a lack of communication globally with the different with different countries that led to a slower response. And I think, this also speaks to the fact that closing borders doesn't really work. So if we've isolated a virus in India or South Africa, a variant of concern, locking those borders down doesn't do anything. That virus is probably everywhere, and it's just been isolated there. And we've learned that time and again here with these variants that, we've had these travel bans and it doesn't do anything. The virus is already spread. We have a very global community. There's lots of travel from these areas to other areas, and it can quickly go. And we know that even though Washington State was where it was first identified in the US, going back and looking at records and doing viral testing, they found that it had been here a lot longer than was thought. And I think they have data from California for sure that showed that that patients who had died from respiratory illness, even early January and late December, there was identified SARS-CoV-2. So yeah. So in terms of SARS-CoV-1, I think it has to do with the viral dynamics in particular compared to SARS-CoV-1 compared to SARS-CoV-2.
Any other COVID questions before she moves on to the next topic?
Great.
I was wondering, is there any concern that Paxlovid might no longer be effective as new variants develop?
That's a good question, but the area of direct antiviral activity is actually very stable in terms of variant to variant. And so it's not, I don't think that there's an immediate concern unless there's a significant change in the virus. But with these variants, we still expect excellent activity. That's why these direct antivirals have persisted while the vaccines and the monoclonal antibodies have not. Because there have been these significant changes in the variant. So I think these direct antivirals are still our mainstay, going to be our mainstay for treatment. And I just want to point out that the efficacy here is quite good compared to other antivirals we have, like for the flu. We know the efficacy for oseltamivir is not as good. And when we look at outcomes, we're looking at outcomes for decreasing symptomatic infection. And we know that they're not that great in terms of reduction in one or 2 days of symptoms. But when we look at Paxlovid in terms of prevention of hospitalization and death, as well as remdesivir, is really quite a game changer in terms of our most vulnerable patients and offering really effective treatment options. All right. So moving on to a different infection. This is a gentleman that I saw in mid-May, mid to late May of last year, who presented to another clinic with penile lesions. He had visited a friend in London in early May, with whom he had anal insertive intercourse and shared a bed for a few days. And he returned to the US in mid-May and developed penile lesions that weren't painful initially. He went to urgent care, was diagnosed with herpes. They swabbed and treated him empirically, but the swab came back negative. And they didn't really offer any additional treatment. So he went to another clinic as he had no improvement and these lesions were getting bigger and painful. And then he actually said, hey, I heard from my partner in London that there's this thing called monkeypox, which is now called mpox. And I'm wondering, should I be tested for that? So then the provider at that clinic said, I don't know anything about that, but I'll call public health, who then coordinated testing. And these were the lesions on his penis at that time. They'd actually become more numerous and also became confluent. And there's a lesion that when I saw him on his lip as well. And then that was on his ankle, but at that point he had probably over 50 lesions throughout his body. So what is mpox? And this is monkeypox is how it was described. It's still the term, but they're transitioning to mpox in all the literature. So just to make it a little bit just less stigmatizing, but it was actually first isolated in 1958 in monkeys, and that's how it got its name. And they were shipped from Singapore to Denmark. But the first human case wasn't identified until 1970 in the DRC. And then we didn't really hear a lot about it globally, although there was probably cases ongoing. But there was sustained human-to-human transmission documented in the DRC, meaning not just one-off case from one person to another, but multiple cases linked to human transmission. And then some of you might remember it hit closer to home in 2003, which there was 53 cases, and they were mostly in the Midwest, associated with these giant Gambian rats that were co-imported with prairie dogs. And these prairie dogs, which look quite cute, were sold as pets. And the pets that they got, these were infected with Mpox and then infected their human owners. And then we didn't really hear much about this in the United States, although things were still happening. In 2017, there were 183 cases across 18 states in Nigeria. And then this was thought to actually reflect declining smallpox immunity, as well as increased interaction with animals. So when we think about urban centers expanding into less urban centers and encroaching on animal environments and more interaction of humans with animals, that is what the concern is, that there was more risk of a transmission of zoonotic diseases to humans. And then in May of 2022, the first cases of Mpox were noted in the UK in a new mode of transmission that had not been reported before with men who have sex with men. So a sexually transmitted Mpox infection compared to what had been described differently from touching lesions, whether sexually or not previously. And so most of the cases that we've seen in the global outbreak from 2022 have been focused on MSM. So this is where we are today, 30,000 cases in the US, and you can see that this is much less than in what we're talking about on order of scale compared to COVID, and the deaths are also quite low. Although I will say the deaths are almost all in immunocompromised individuals, particularly with advanced HIV and CD4 counts less than 100, where we saw fulminant disease and multi-organ failure. And this is the graph of where we are today with it. You can see this huge spike after June with the first smattering of cases in May. And then what we've seen is kind of a rapid decline. There are some things that went into this response, and I think we learned some lessons. Even though we learned some lessons with COVID pandemic response, we learned some more lessons with Mpox response and kind of our slow mobilization of a vaccine that we had actually been sitting on for a long time, and mobilizing that vaccine, and particularly outreaching communities at risk that we learned about. One of the things that I will say that led to this huge spike is that there are a number of pride events, gay pride events that happen in June throughout our country. And you can see that big spike after June, and I myself saw many patients who had been to pride events and developed Mpox after attending those pride events. And so I think we're going to see another push for Mpox vaccine soon, particularly for individuals at high risk for more severe fulminant disease, like our patients with HIV, advanced HIV. So transmission, zoonotic, rodents are thought to be the natural reservoir, and like was mentioned, the Gambian rats and the prairie dogs. Animal to human transmission is possible, human to human transmission, particularly with infected fluids. And we know that those lesions are highly infectious. It's thought to be rare to have a respiratory droplet, although we are very cautious in the inpatient setting about isolation of these patients. This is what the progression of lesions looks like. They start off as a macule, then a papule, and then these classic pox vesicles, then pustules, and then you can see kind of the scarring that can occur there. There are two vaccines, ACAM 2000 and Shireesha. That's the currently used vaccine. ACAM 2000 has been around for a while, but I don't know anyone who would opt for ACAM 2000. It is a live replication competent vaccinia virus. So when I showed you those phases of infection, that is what happens with the vaccine as well. And getting that scarring is actually tells you that the vaccine took. And so for some of us who were vaccinated against smallpox as a child, you probably have that scarring. It is administered by pricking the skin to cause a local infection, and you actually need to do wound care because it can get super infected. And then this is obviously not an option for people who are immunocompromised, as virus can spread. And there is a potential for myocarditis risk, although relatively low, but not that low compared to other vaccines. And it's contraindicated in a number of people, particularly those with who are pregnant, heart disease, immunocompromised, and chronic skin conditions where you can have more vigorous cutaneous reactions. So that's kind of what the take process looks like. So what do we use now? We use Shireesha, which is a live non-replication competent viral vaccine. It's 2 doses, dosed 28 days apart, and you're considered protected 2 weeks after the second dose. There are some local site reactions that can occur, and it's okay to give to pregnant and immunocompromised patients. One thing that did happen is because there was a vaccine that was stockpiled, but apparently many doses were not usable due to the way that it was stored or thawed. And so we actually had a vaccine shortage. As I mentioned, it was slow to mobilize as well. And so the FDA and the CDC endorsed use of a intradermal route of administration, which can stretch the amount of vaccines to up to 5 times, because it's a 0.1 dose versus a 0.5 dose, which was given subcutaneously. But we mostly got about 4 doses per vial. One thing that we heard a lot from patients is that you can get hyperpigmentation at the site in the forearm where it's given. And that has led to some stigma around receiving Mpox and kind of the telltale sign of getting the Mpox vaccine. So we are actually, because vaccine supply has improved, we're offering sub-Q at this point. And so, one thing I would note is that we don't give it to patients with keloids and because of the potential, this intradermal dose, because of the potential for keloid formation. So indications for vaccine, high risk contact. So if you've had a contact with a patient, getting vaccinated as post-exposure prophylaxis, best if given within days of exposure, but may give up to 14 days after exposure. And then we focused on pre-exposure prophylaxis, focusing on the highest risk of patients. So MSM in particular, and then MSM who are immunocompromised is our greatest focus of patients. Okay, any questions about Mpox?
Well, a similar question to before. Why does a virus that we've known about for a long time and it appears to be quiescent have an acute spike like that?
I know, it's a really good question. We know that human to human transmission has been going on. And so that jump to that sexual transmission, it is interesting. I think I don't have a really good explanation for it. The cases in Nigeria were probably underreported, and many people had 1 or 2 lesions that may not have that 183 cases. We do know, interestingly, that the clade is different than that outbreak. That clade was associated with much higher mortality, and like up to 10% mortality. And what we saw, even though that this was much more transmissible, that the mortality was lower. And when we think about kind of viral fitness and what the virus can do to maintain its replication and its life cycle, is you don't want to kill off all the hosts. And so if you have a more attenuated virus, but that's much more transmissible, it's much more ideal for these big outbreaks. And that's what I think we saw here, is that this is a little bit different of a clade than what was seen in the Nigerian outbreak, and which is why we saw many thousands of infections globally with low mortality. Okay. So this is a different case of a 52-year-old man who presents with acute onset headache, nausea, vomiting, fever, muscle pain, and he develops lower extremity weakness with absent reflexes. And the sensory exam is normal. This is a real case. This is not a case that I saw. Any thoughts about what this could be? Okay. So polio, this was another big hit in 2022. And Len, you bringing up the old viruses reemerging, why reemerging now? And so this was a case that was in New York that in a particularly under-vaccinated community, due to religious reasons, they have a low vaccination rate. And then what they did was they went back because this person had no travel. They said, where the heck did he get it from? And they did an exhaustive evaluation. And one of the things was wastewater evaluation, which had become big with COVID, surveillance with wastewater, and they detected polio in the New York City wastewater, and particularly in these areas that had under-vaccinated communities. So what do we do with this information? We know that there's universal vaccination for children, although there have been outbreaks related to low vaccination rates, particularly for measles in communities. So this is another one of these examples of why vaccination is still really important. It's a human enterovirus caused by RNA virus. And rarely, most infections are mild diarrheal infections, but it can rarely cause acute poliomyelitis that can be caused by a wild type virus or from the oral polio virus vaccine virus itself. So a number of years ago, we switched from the live attenuated vaccine to a inactive vaccine routinely. And that was because we did see a case of vaccine transmitted infection to an immunocompromised host, a child that was shedding in his stool vaccine derived virus that then went on to cause poliomyelitis in a immunocompromised child at home. So because of the potential for transmission of the vaccine strain, we shifted to a non-live vaccine or IM vaccine. However, globally, that is not the case, that there is still a live vaccine used in other parts of the world. So you can see here, this is the most recent map of where polio is, and you can see this one green dot here in New York where we didn't have any previously. And this is a vaccine-derived strain of poliovirus. You can see that the wild type is pretty much very limited to a few countries in the world. And because there have been some huge efforts at polio eradication with increasing vaccine globally. So why did this happen? There's been lots of theories about why this happens, and but we do know that under vaccination in the community is really one of the big things that leads to this. I saw a talk from the New York Public Health Department at one of our national conferences about the best strategy, and they actually argued against vaccinating the population in its entirety if you've already been vaccinated, but they did recommend all the children who have not been vaccinated and then adults who have not been vaccinated to get that catch-up vaccine. Just because we do know it's in the wastewater. Interestingly, when there's one case of poliomyelitis, we always think, how many asymptomatic or mildly symptomatic cases are we missing? And how big is the problem for polio? And we would have expected more cases than the one, and that didn't happen. And we don't really know why that didn't happen. We assume, given that the polio virus was in the water, that there is under-vaccinated communities, we figured there would be more poliomyelitis, and there wasn't. And so we don't really know why that is. They didn't offer any epidemiologic explanations for that. But we are on alert that these infections that we have thought are other places are not other places. They are in our own backyard. So poliomyelitis, even though it's a rare manifestation, acute flaccid weakness due to anterior horn cell injury is what people experience, and it can be associated with symptoms of meningitis, and that weakness can progress. Here is just sort of what this is from the New York Times actually about this case. And kind of, it was the first case in nearly a decade, and that previous one was vaccine derived, like I mentioned, to an immunocompromised host. The plan is still to try to eradicate the world of wild type polio by 2026. We're nearly there. It's only endemic in 2 countries. But these barriers keep coming up, like vaccine derived strains. So more on polio, hopefully not in our country, and people will continue to get vaccinated because this is a vaccine preventable disease. I will note that the vaccine derived strain, that vaccine we do not use here. So just a point of an important point to make. Lastly, there's a couple more things that I want to mention. In the news, we've heard a lot about Marburg virus, and I think this was just last month, the CDC Health Advisory Alert that went out that there are outbreaks in Equatorial Guinea and Tanzania, countries that have not had these infections before, and human-to-human transmission and in these countries as well. There are no confirmed cases of Marburg virus in the US. And as you recall, when we had that Ebola scare, we had our disease preparedness already for that. And similarly, the CDC asked to mobilize some of those things in case patients present to the US and from other countries who are symptomatic or who then subsequently develop symptoms. It is really rare at this point, but it's highly fatal. Up to 88% of people die in these case series and previous outbreaks. It's related to Ebola virus, so that hemorrhagic kind of virus. And there is easy human-to-human spread, which is why quarantining and response efforts at controlling infection are really, really critical, similar to Ebola virus. So I don't think you need to worry about this, but you may hear about it in the news, and people are doing, it is recommended for travel screening right now to talk about that. Lastly, I wanted to give you a rundown of foodborne outbreaks in the last year. I don't know if you've already had breakfast or if this will deter you from breakfast, but these are kind of all the different things, and there's probably more, but this is from the CDC. Contaminated flour with salmonella, frozen strawberries, listeria outbreaks, another salmonella outbreak related to alfalfa sprouts. And I will say, as an infectious disease provider, these microgreens and alfalfa sprouts are really hard to clean and really thoroughly clean, and they are a hotbed of bacterial diarrheal outbreaks. So I tend to not eat those things just because they're really hard to clean. Raw oysters, mushrooms, deli meat and cheeses, fish, even frozen falafel, and of course our cheeses and our unpasteurized cheeses. So we've seen lots of outbreaks, and this year, interestingly, and in just the last month or so, we've seen some rotavirus in adults. Actually, we know that children are vaccinated, but we've seen several cases just at Harborview of rotavirus in adults. So lots of diarrhea going on around there to be worried about. So be mindful of the foods that you're eating. And I think this is just telling of kind of our state currently, that we are probably going to see more and more of these outbreaks, and to be mindful of our food and water safety. All right. I am going to stop share here, and then I'll be happy to answer any questions that you have.
I'm curious, the polio case, was that an ultra-Orthodox Jewish community in Brooklyn?
It was in I think in Rochester County in, is that the name of the county?
And Westchester is north of.
Yeah, Westchester County, and it is a Orthodox Jewish community.
So if you're not vaccinated for polio, can you not go to school in the US?
So that is Washington State, I can speak about, had a very low childhood vaccination rate for, measles, for all the childhood vaccines. And then they instituted a medical clearance or medical exemption. So even if you had a religious exemption, you actually had to go and discuss it with a provider, your pediatrician, your family doc, or whoever, and they had to write a letter saying, I attest to their religious or medical exception. And the whole point of that was to counsel about vaccines. So an opportunity to counsel about vaccines, but just having to do that extra step and get that medical letter led to increased vaccination, because people were like, I'm not that against it. I don't want to make an appointment with the provider and listen to their spiel about why. And then that actually improved rates. We don't have a mandate, though, in Washington State for kids to get vaccinated. You can have a religious or medical exemption.
Didn't we have some practitioners unethically writing those letters?
Yes, we do. I'm sure we do. And and with COVID, we had lots of unethical providers prescribing, lots of ivermectin and things like that too. But yes, there were people, but still the rates of vaccination increased, even with those people writing letters, that there were more people who got information about vaccines rather than blankets saying no. And so I think it's hard because population level health versus individual autonomy is always the issue. And so vaccine mandates have been really challenging, and there's a lot of pushback for vaccine mandates. Even here at UW Madison, you probably heard, we had somebody in our clinic who refused and left the job because they didn't want to get vaccinated. So it is a real hot button issue about vaccine mandates. But yes, it would be a lot easier if everybody just got their vaccines.
Other questions from, we've still got quite a number of people listening.
Hi, this is Vinod Doris. I'm one of the community allergists. Thank you so much for your wonderful talk. Really, very informative. I had two questions. One was again from the vaccine hesitancy and vaccine beliefs. Is there again data with regards to MD or medical school providers versus naturopaths in terms of many of our patients probably have naturopaths or other integrated medicine providers as their primary care in terms of vaccine follow through or writing these exemption letters. Is there a difference? The second question was go ahead.
No, go ahead.
No. Second question's unrelated. Maybe I'll probably ask the second question in just a bit.
Okay. I don't know of data between naturopathic providers and allopathic, osteopathic providers related to vaccine, promoting vaccine hesitancy or not vaccinating patients. But that is an interesting question. I am also seeing a lot more patients who are getting integrated care or naturopath that are sent to infectious diseases. What always astounds me, though, and I'm curious to see if others have this experience, that how many medications and how many tests the naturopaths give their patients. So it's there's a lot of testing for infectious diseases and from naturopaths that I see, and maybe that's my bias because they're sending them to me for these quote unquote infections. But I don't know about vaccine data.
I'm sure you all get the mold toxicity questions quite a bit from those scenarios. I suspect mold infections
and Candida.
Right, or fungal infections. Candida, fungal infections. Again, maybe this is a larger question. If we learned anything from the pandemic, when is the next big pandemic and how better prepared are we? And now that we're coming out of this pandemic, at least as the proclamation goes, everybody's so tired that are we going to be again in the same boat?
Yeah, I think that's a really good question. And I think, we were 2 years into the COVID pandemic when Mpox hit, and it was clear how non-integrated our public health systems are to be able to rapidly respond to a pandemic. And some argue, well, we were with an outbreak within a pandemic that made it more challenging. There was a lot of fatigue and burnout and being able to respond. But I do think that that's going to be the case. And we do really need to have a more integrated public health system that communicates a lot better for us to be able to respond quickly. As we know, many of these public health jurisdictions are underfunded. And then, we're taking away kind of this emergency fund. I think our senator here has really argued, Patty Murray, for enhanced preparedness funds and having a more of a person who's always kind of thinking about this and coordinating it. And I don't know where we are with that. I think it's really hard politically to get change. But I do worry. I think some of the infrastructure is there, some of the knowledge is there, but it's just a lot of it is a coordination of these things and communication.
Is COVID going to become an annual vaccine like influenza?
I think it probably will. I think this booster that just came out for a smaller number of patients are 65 and older and immunocompromised. I think we'll probably in the fall see more broader recommendations going into our respiratory viral season. I think that's kind of where everything is pointing. If we can get it down to one vaccine a year, that's pretty impressive given how many vaccines we've probably all already gotten for COVID.
Well, thank you for a brilliant talk. The problem with giving a brilliant talk is I'm going to invite you to do it again next year.
Shireesha, one last question. I know a number of singers who are elderly, over the age of 65, and because the studies show that the singing is more of a production of respiratory droplets, and so many of them come to me and ask me, should I continue to wear a mask and do precautions? And I generally say, yeah, it's not going to hurt you. What's your thought about that?
Yeah, I think if people want to, I think it's personal, weighing your personal risk, and I think I think I wear a mask, obviously in the hospital. If I'm going to the grocery store, I actually wear a mask. If I'm in an outdoor event, I don't wear a mask. And so I think it's kind of, risk assessment for the most part. And then if I'm on a plane, I'll wear a mask. And so a lot of indoor settings, I just, why risk it? But I think at this point, people are making their personal decisions about weighing risk and benefit. If you're 65 and you're in a crowded setting or indoor singing setting, I think it's not a bad idea.
Right. Thank you.
And get the booster too. All right. Thank you, everyone.
Well, thank you. Bye-bye.